Good afternoon, everyone. I'd like to thank the organizers for giving me this opportunity to speak to you about stroke in women or cerebrovascular disease in women. And I'm really humbled to be speaking after such two excellent presentations. So let's see. So I have no disclosures, and I'm going to try to highlight, okay, so I should move this. Okay. So I try to highlight the differences in cerebrovascular diseases between men and women. What are the unique risk factors for the females that makes them different than males? And is there any difference in outcome among women compared to men after ischemic stroke or vascular event? And as pointed out earlier, the disparity in clinical representation. Thank you. Okay, so first of all, is there a difference? I think this way you can see me better. Is there a difference between men and women? So this is from the United States statistics, and according to 2018, stroke was the third leading cause of death in women compared to men, while in men it's the fifth leading cause. So as an overall cause of death, stroke is the fifth leading cause of death. But when you segregate it by sex, females, it's the third leading cause with, it's causing 6.2% of all mortality, while in men it is the fifth cause. Cardiovascular disease is the first lead cause in death in both groups. Also, the case fatality, so the number of deaths due to stroke compared to total ischemic stroke cases is higher in women. And this, so the percentage of females that die from stroke is higher, and this persists across all age groups. So the blue is men. So the total number of men who experience ischemic stroke, up until the 8th decade or 7th decade, men have higher number of strokes compared to women, but the fatality rate, the percentage of women, of people who die from the stroke, is persistently higher. And then, as we will see in the later slides, after the 7th decade, you see more women, the total number of women having ischemic strokes higher. This is because women live longer than men. And then we have more AFib as well. So I understand we have a heterogeneous audience. So I just wanted to explain what do we mean by stroke. So most of the time, when we say stroke, we mean ischemic stroke, but stroke is an acute neurological event, and some people would include different neurological, or it would be more appropriate for me to say cerebrovascular disease rather than stroke. So we have the most common one, which is more than 80% of cerebrovascular disorders are ischemic stroke. So ischemic stroke, a clot blocks a vessel, the brain tissue dies, and then you have this hypodensity if you're looking at a CT scan. Second most common, so this is overall. Second most common would be intracerebral hemorrhage. So there is bleeding into the brain parenchyma. And the third one, which is less common overall, is subarachnoid hemorrhage. So subarachnoid hemorrhage is caused by rupture of an intracranial aneurysm, and then the blood is spilled in the subarachnoid space. It's not in the parenchyma, so that's the difference. So another kind of representation, so when we say ischemic stroke, so probably either small vessel disease, so it gives you a lacunar stroke. It could be arterial emboli, so atherosclerosis and large vessel disease, which a patient would need carotid endarterectomy. If you have a rupture of a blood vessel, you get intracerebral hemorrhage, and the intracranial aneurysm, like here, and if it ruptures, it gives you the subarachnoid hemorrhage. And cerebral vein thrombosis, which is the equivalent to deep venous thrombosis, but in the brain sinuses or draining veins. And this is a disease mostly of the women. 70% of all cerebral vein thrombosis are women. And reversible cerebral vasoconstriction syndrome, which we're getting to know more and more about it, also predominantly affecting women. So there is a difference in disease spectrum. So overall, ischemic stroke is more common, right? And it is more common in women and in men. But if you look at the presence of intracranial aneurysms and subarachnoid hemorrhage, it is more common in women. In regards to intracerebral hemorrhage, it is more common in men, or more frequently seen in men than women. What about ischemic stroke? So ischemic stroke incidence varies by age, as I showed you the graph earlier. So in age less than 30 years, women are more likely to have ischemic stroke than men. So incidence is higher in women. And you can think of certain things such as the use of oral OCPs or certain lifestyle. In midlife, which is up to it says here 80, but you can also say to the 7th decade or after 65 years, the incidence is higher in men, and at an older age, so 7th and 8th decade, may be equal, but it seems there's a trend that it's higher in women because women outlive men. Women develop atrial fibrillation as a part of the aging process. Another interesting fact, we know that overall men have more cardiovascular disease. Now the first presentation, so cardiovascular or vascular disease, the first presentation of vascular disease in men is usually by a heart attack or coronary artery event, while in women, their first presentation seems to be ischemic strokes. I find this interesting. It still happens at an older age, so women, when they experience their first vascular event, usually 6 to 8 years older than when men experience their first vascular event. So what the risk factors? So even though we have known general risk factors, these different risk factors confer a different effect or impact on people depend on the sex. And there is also risk factors that are unique for women only. So this graph represents these risk factors that we'll be talking about. So there are the general risk factors that may impact women more, and there are risk factors that are only unique in women. So I think Dr. Khadija gave us a very comprehensive review. I don't think I have much to say other than emphasizing the fact that diabetes is evil, and diabetes increases the chances of having stroke by twofold, whether that's overall men and women, usually lacunar infarct, so small vessel strokes. And then if you try to segregate it by gender or sex, a large meta-analysis found that women with diabetes have a 27% higher chance of getting a stroke compared to men with diabetes after controlling for age and other risk factors. So women with diabetes, higher risk of ischemic stroke. Also, the women with diabetes have a twofold increase in risk of fatal strokes. So not only that they have higher chance of having ischemic stroke, but there's also a higher chance that their stroke is going to be fatal. It's going to kill them compared to men with diabetes. Am I doing okay? After controlling for risk factors. This is an interesting paper that they also separated by gender, also by ethnicity, and they divided, like they did the risk analysis by fasting blood glucose. So you see women have higher risk of ischemic stroke even when you match for glucose. And you see even at the lower glucose, so between 100 and 125, women tend to have higher risk compared to men. It crosses here. And yeah, this is a little funny, but overall higher risk. Now, we also hear the term of that diabetes is a stroke equivalent. I think among cardiologists, they might say that diabetes is a MI equivalent. So where did that come from? So in this pooled analysis, they found that women who have diabetes have the risk of having a fatal stroke is the same as a woman who had a previous ischemic stroke. And that's where it comes as the term stroke equivalent. So she had diabetes, no previous stroke. Their chance of having a stroke that will kill them is the same as if you have no diabetes but had experienced a previous ischemic stroke. Okay, and atrial fibrillation, I think Dr. Amar also gave us a very nice review, so a lot of what I have here is emphasizing what previously was mentioned. So atrial fibrillation is more common in men, or higher risk in men, twofold than women. However, because women outlive men, and they kill men. So they outlive men, and atrial fibrillation is a disease of aging, then we have the total number of women with atrial fibrillation is higher. Also, women, when they experience an ischemic stroke due to atrial fibrillation, it tends to be more severe, and leads to a higher disability, higher functional limitation. Okay. And this is why, and then different observation studies or cohorts found that just being a female is an independent risk factor for complications from atrial fibrillation, and this is why being a female is added to the risk stratification, the CHADS-VASc score, which we do use every day almost. So we said that there's a higher number of women that have atrial fibrillation, and when women have a stroke due to atrial fibrillation, they are more likely to be disabled, they are more likely to die compared to men. But then you have this treatment paradox. So despite all of what we know, it seems, and I think it was also pointed out in the earlier talks, that women are less likely to receive anticoagulation compared to men. Why is that? So these are the numbers. It's open to speculations. Maybe they are older at age, maybe because they're older, more frail women, and then the physicians are, more reluctant to give them, worried that they're gonna hemorrhage or whatever. Open to speculations, but we know they are undertreated, even though the studies and the use of oral anticoagulation, especially the newer direct anticoagulation, have the same efficacy, and the number of complications such as hemorrhage is the same. So the efficacy, it's as good in preventing strokes in both genders, but it's less likely used in women. Hypertension, there's no real consistent sex differences in terms of their association with ischemic stroke risk, so I'll leave it at that. Some data are coming, but it's conflicting. Maybe higher in women. The same goes for dyslipidemia and physical activity. So dyslipidemia, how it affects the risk for stroke, but as Dr. Khadija mentioned, women are less likely to be given high-intensity statins because they wonder about their frailty, or there's some suggestion that lower LDL can give you ICH, intracranial hemorrhage. But yes, we tend to use it less with women, or less high-intensity statins. The effect of physical activity in terms of protective effect is equal in both. So both men and women will benefit from physical activity, no differential. With body mass index, there is suggestion that women with higher body mass index and waist to hip ratio are at higher risk of strokes or ischemic events. Now, migraine, I find this very interesting because there is a lot of questions. Well, we know that migraine is more common in women. Women are 4 times more likely to have migraine than men. And then we have the data that shows that migraine with aura, and when we say aura means focal neurological symptoms that happens preceding the migraine, sometimes at the same time as the migraine headache. And the most common aura is the visual aura. So you have lights, you have flashes, zigzag lines, whatever. But you can also have speech aura, so speech impairment. You can have paresthesia as your aura, or you heard hemiplegic migraine, so you can have motor deficit as the aura. So people, men or women, who have migraine with aura have 2 to 3-fold increase in the risk of ischemic stroke. And then, this is overall, but then we know that women are more likely to have migraine. If you have migraine with aura and you take OCPs, your risk increases by 7-fold. If you migraine with aura, OCP, and you also smoke, then you hit the 9-fold increase in the stroke risk. Well, we have this information, but if a woman have migraine with aura, should I give her aspirin? We don't really have data to support or not support giving aspirin. So we really don't know what to do with this information, but it might be reasonable if they have other risk factors. But don't let them smoke and say, okay, I'll give you aspirin. That's not okay. So back to the risk factors. So we talked about the general risk factors and that impact women more. Now we're going to go to the female-specific risk factors. Okay, I don't have much time, but hormone effect, as we said, the use of OCP, oral contraceptive pills, increases the risk of stroke by 2 to 3 folds. The HRT is a big, as my mentor used to call it, is the biggest translational research failure because, we think women have a less risk of cardiovascular events before menopause, and the thought is, it's because of the estrogen, anti-inflammatory, cardioprotective effect, so why don't we give women after menopause estrogen? But then several studies showed that no, that actually did the opposite. It gave them higher risk of ischemic strokes, so there is something that we don't fully understand. However, we do have evidence that transdermal patches are less evil. They're less likely to give you ischemic strokes. And if somebody, for primary care doctors, if you were to give a hormone replacement therapy, it shouldn't last more than 10 years post-menopause and less than the age of 60, whichever comes first. Early menarche and late menarche. Again, this is another example where, what we think makes sense or logic doesn't really translate into benefit in real practice. So early menarche increases the risk of ischemic events, they thought, because that increases your total life exposure of estrogen. But then at the same time, late menarche is also a risk for ischemic stroke. So that's a little confusing. Multiparity, so women with higher children who give birth to more than 5 at a higher risk of cerebrovascular disease, but breastfeeding has a protective effect. But then you can also ask, if she gave birth to more children, she probably breastfed more than the one who had less children. But then, where it doesn't really make sense. But these are associations, we don't really know. And again, these are coming from the West. It's not our population, but just point it out. And big topic, as mentioned multiple times, the pregnancy. Adverse pregnancy outcome, which include preterm delivery, gestational hypertension. I'm surprised diabetes is not one of them. Preeclampsia and fetal growth restriction. These are associated with lifelong increased risk of cardiovascular, cerebrovascular disease. Especially hypertensive-related disorder will double the risk. And if you have preeclampsia at an earlier gestational age, this increases your risk of stroke 5 times. Peripartum is only 3 days, 2 days pre-delivery, 1 day after delivery. You have a very much higher risk of ischemic stroke, ICH, and subarachnoid. Postpartum up to 6 weeks after delivery, again, higher risk, but of ICH and ischemic stroke. This is a relative risk, so it's kind of exaggerated, but the risk is there. Okay, and let me just show you a case because I don't think many people are familiar with this condition. So this is from my practice, actually. I saw this lady last March. Thank you. She is 28-year-old, and she is para 3. She presented with recurrent thunderclap headaches, which started 2 weeks after giving birth. The pregnancy was uncomplicated. She didn't have any hypertension during pregnancy, no preeclampsia, whatever. She was seen somewhere else and had an MRI brain, unremarkable, given propranolol. 4 weeks later, she's still having the same headaches. So when I say thunderclap headache, it means it starts really, so sudden, acute, reaches maximum severity within 1 minute. So with that history, I think of, so we ask for the MRA, MR angiogram of the head, and you can see how the vessels, they don't look like a young 28-year-old woman. They look like an 80 smoker, diabetic, whatever. So you see how the attenuation, multifocal narrowing of the blood vessels. So this is a case of reversible cerebral vasoconstriction syndrome. And I hope this will intrigue you to read more about it, but it's more common than we think. I think it's underdiagnosed in our community. So they present with thunderclap headache and the vascular imaging characteristics that you saw, and more common in women. And thank you very much. My time is up. But basically, can I add? So basically, what I want to say is, like, identifying that there are certain risk characteristics that are more common in women. Unfortunately, these characteristics are not shown or not incorporated in any kind of risk stratification. So we know they are higher in women, but we don't know how to translate that into day-to-day practice. Women with adverse pregnancy outcomes, how do we know how to screen them? Is there any guideline on should I initiate certain treatment earlier? Should I do certain cardiac follow-up or vascular follow-up sooner? We don't so hopefully your research will highlight these things and the disparities like highlighted earlier. Thank you very much.